Good evening, everyone. I'd like to welcome you to a joint event this evening being hosted by both the Graduate and Professional Student Affairs Group and the Center for the Advancement of Interprofessional Education and Practice. The title of tonight's event is Better Together, Real-World Strategies for Your Interprofessional Collaborative Practice. The way the evening is going to work is I'm going to have a few brief remarks, and then we're going to introduce members of our panel. And then I have some questions to get the conversation started. But really, what this event is designed for is to provide an opportunity for you, the audience members, to engage with our panel members and talk a little bit more about what real-world interprofessional practice is like. Because sometimes you might have heard from some of your classmates who are out on clinical rotations, there can be a little bit of a difference between what you're learning in the classroom and what's actually happening once you're out in the clinical setting. So that'll be one of the themes we'll kind of dive into a little more as we have an opportunity to talk. My name is John Vitale, and I'm going to be the moderator tonight. I'm relatively new to UNE, but I'm not new to interprofessional practice. Just a little interesting fact, I'm the second person in the world to have a PhD in interprofessional education. So I'm one of the very early adapters in IP, and it's a subject that's very important to me, and I'm really honored to be here tonight talking about it. What I'd like to do is thank a few people that were instrumental in putting tonight's event on. I'd like to thank Chris McCary. I think Chris is here. Oh, thank you, Chris. I'd also like to thank the staff in CAPE, and that includes Michelle Coate, Chris Hall, and Liz Crampsey, who are mostly in the back. Thank you. Thank you for putting this event together, and I'd like to give a special shout out to two other individuals that are instrumental in pulling off events like this, and those are Lee Coate and Dave Dadiego in the back here. So thank you, gentlemen, for all of your help in pulling this off. One little bit of housekeeping on your table. What you'll find is a survey link that we're using to do a couple things. One of the things is we're using it to track attendance because attending this event may count towards your interprofessional honors distinction if that's something you're working towards as a student. The other thing that can be used for is a survey to help provide feedback so that we can use that information to try to continue to make these programs as meaningful as possible for all of you. So what I'd like to do now is have an opportunity for each of the panel members to introduce themselves. And I think what I'll do is I'll start closest to me and work our way down. So if you could just share your name, if you have any previous ties to UNE, as I know many of you do, and then talk just briefly about what you do professionally.
Okay, so my name is Megan Getty. I'm an occupational therapist at a private outpatient pediatric clinic in Arundel, and I graduated from UNE with my undergrad degree in 2021 and my MSOT degree in 2023.
I'm Katie Finch, and I'm a clinical social worker. I graduated from UNE Graduate School, Social Work School, in 2018, and I have many jobs. I teach an undergrad class in the social work department in Biddeford in policy. I have a private practice where I work with adults and teenagers, mostly main care clients. And then I also work as a survivor interviewer for the Maine CDC Maternal, Fetal, and Infant Mortality Review panel.
So my name is Miguel Saldivar. Unfortunately, no ties to a UNE on my side, but I am an infectious diseases attending and an associate director of epidemiology and infection prevention at Maine Health, and we'll talk a little bit more about what all of that means.
Hi, I'm Marley Martin. I am a pharmacist. I work at the Hannaford Pharmacy in Sanford. I'm the manager there, and then I'm also a per diem clinical pharmacist with Maine Health on the centralized refill team. And I graduated from the University of New England in 2022.
Excellent. Thank you, panel members, for joining us. We really do appreciate having you here this evening. One of the first things I wanted to kind of start the conversation off with is when we think about interprofessionalism, one of the big things we think about are all the different professions that you work with when you're practicing. And I'm wondering if we could just kind of go down the table and talk a little bit about, again, what your profession is and the different members of the healthcare team that you might regularly interact with in your role.
So again, I'm an occupational therapist in a pediatric clinic. In our clinic, we have OTs, physical therapists, and a speech pathologist. So they're part of like my daily team that I interact with. And because I'm doing peds, I interact with the parents a lot, so they're part of that interprofessional care team as well. And then outside of our clinic, I talk a lot with other speech pathologists, some social emotional group clinicians, PCPs, and neurologists, sometimes neuropsychologists as well, about different carryovers and things like that.
I think in a lot of ways, social work touches all the health professions, and I feel like I have worked with somebody in every single health profession at this point. But as a caseworker, which I was for a long time, I spoke a lot to dentists. And I also spoke a lot to PCPs, nurse practitioners, and pharmacists. And a lot of that was around advocacy for the needs that my clients needed and them needing someone to sort of massage the communication. And in my job with the panel, I work a lot with nurses, doulas, midwives, OBGYN, and also EMTs. I think that covers it.
So for me, I would say there are two main aspects to my profession. The first one is as an infectious disease consultant, so a physician. And like most physicians, you'll interact with nursing staff, with primarily, I would say, nursing, PT, OT, social work, really a lot of the health professions, bottom line. The second aspect of what I do is the epidemiology side / infection prevention, and that is where things get even more fun because, I started getting interested in that field in 2020. You may remember some stuff that happened that year that most of us, I think, would rather forget. But by virtue of getting involved in that, all of a sudden I was talking to not only all of those fields, but people in leadership within those fields. I was talking to hospital administrators, to, executive level folks, to financial folks, to leadership from the groups that dietary, folks who clean the rooms, and what are the implications for them as they go through their day-to-day jobs in a scenario like what we had in 2020. So yeah, I think.
So in my retail setting job, which is Hannaford, I work most commonly with pharmacy technicians. That's probably a career in healthcare that I feel like has been developing in most recent years since COVID, 2020. We've had a lot more investment in our technicians as far as vaccinating and certification programs. So that's a up-and-coming healthcare professional field I see us developing a lot. But I also reach out a lot to physicians, nurses, MAs, whether it's just a question about a prescription. I work for Maine Health as well, per diem on the centralized refill team, and that's a lot of back and forth with an MA team that I work with about processing prescriptions and answering questions to patients. So for the most part, it's nursing staff, physicians. I have worked with a couple social workers that are advocating for their patients, or I have a couple group homes that use our facility, and so we help coordinate it with the social workers that are associated with that group home to make sure the patient's medications are coordinated.
Yeah, so you can see that everyone on the panel here interacts with a lot of people. And I know this will come as a surprise to some of our audience members, especially our students, but believe it or not, when you try to work in big groups and have everything coordinated, it doesn't go always according to plan. And I was wondering if we could ask our panelists if they have any examples they'd like to share of when trying to collaborate and work together maybe didn't work out, and kind of what the outcome of that might have been, if you can share a story there. Anyone with a good one?
So working in a pharmacy setting, I receive electronic prescriptions a lot from providers. There's a lot of back and forth usually of like, I need something clarified. And so it's us calling the regular hospital line. We'll usually get some sort of patient representative who will then jot down a note to pass it on to the nurse, who then passes it on to the physician. And sometimes by the time it comes back to me, the original issue that I called for isn't resolved, and now there's another one that's on there too. So I would say communication can sometimes be a little difficult when it's like you're having to pass messages through a game of telephone. And that's probably the biggest spot where I've seen some difficulty, is just relaying that information in a clear way that makes sense to each member of the team.
Thank you. Miguel, did you have an example?
A couple, but I don't want to take too much time here. But one that is, I think, on the clinical side, scenario you face frequently. Let's say you have somebody complicated medical background without getting in details, and you're trying to arrange discharge, and more importantly, a safe discharge. One of the aspects I've noticed, I don't know, depending on which hospital you rotate through or ended up working on, you may have a completely different EMR system compared to other hospitals where you've trained. The system I'm at right now has the ability to do, in essence, text messaging within the chart. So it's HIPAA compliant, it's private. However, one of the things I've learned very quickly is that a lot gets lost in translation where you're trying to communicate exclusively through text. And I have noticed, I think just the reality of how the world operates right now, the younger generations tend to rely, and I'm giving away my age here, but trying to rely more on text a lot of the time than a phone call. And by the same token, when things get very complicated, I have so frequently found that it's so much easier to just pick up that phone. And a conversation that took you 2 minutes would have taken you half an hour to 45 minutes if you try to go through it by text. So just picking up the phone, talking to the provider, the case manager, the whatever other healthcare team member is involved in the case just saves you so much time, and ultimately has led to better results.
Yeah, I think that's a really powerful message to communicate, just the modality we choose to use when we're interacting with other professionals. Oftentimes there's formal things that occur in hospital, things like rounds that people might be going on, morbidity and mortality conferences, and other types of specialty things which are designed to facilitate that communication. But outside of that, oftentimes, because we're so busy, it's really challenging to find time to communicate with someone. So it ends up oftentimes digressing, I hate to say, into text messages or emails, and oftentimes a lot gets lost in translation, which can be a real problem.
And if I can speak a little bit more to that, the specific example that came to mind, and again, I can't give the details because there's private information involved, but the medical plan had a specific intention that ultimately was safety. And when trying to communicate that through text to the case manager that was trying to arrange the discharge, that did not come through. And it really became apparent when I went and talked to her face to face and explained to her, this is why I'm doing this. And she told me, well, this is why I want to do that. All of a sudden you have that moment like, okay, we're actually both trying to do the same thing, God forbid. And we're just looking at different angles. So the conversation just cut through all of the fog that the text was creating.
Yeah, it's such a tricky problem, especially here in the United States and the way our healthcare system is set up, that most medical errors that are occurring in a hospital or inpatient setting are occurring during handoffs. So they're handoffs from one provider to another, they're handoffs, switching shifts, and things get lost in translation. And when that occurs, there's much greater opportunity for errors to occur. So communication is a really vital part, obviously, to being a positive productive interprofessional team. And there are a couple things that oftentimes pop up in the clinical setting that make the situation a little less than ideal. So one of those things people often don't like talking about, but it's a reality, and it's the medical hierarchy and kind of the model that we have here in the US. And I'm just wondering, have there ever been challenges that you've faced interacting with people that are, air quote, above you or below you, where there's been some miscommunication or not seeing eye to eye based on some of those maybe preconceptions that they have about the hierarchy and their role on the team?
Yeah, I can speak to that. So in a private outpatient setting, I get a referral script from a primary care provider, and then that has my codes for like what I'm seeing a child for. So it could be fine motor, it could be sensory processing, it could be an ASD diagnosis, ADHD, things like that, and that kind of gives me my base. And then a parent will fill out the paperwork and I'll learn more information, and then I'll eval them and we'll write goals and all of those things. And I recently had a kiddo that I was seeing for feeding therapy concerns. And I wrote out all of our goals, and in my evaluation at our clinic, we do a full comprehensive, so I'm not just looking at some feeding concerns, but also strength, fine motor, all of those things to make sure I have a really comprehensive idea of like, where are these feeding concerns coming from? Is it an ability to attend to sitting at the table and eating? Is it from an oral motor strength perspective? Is it from like a fine motor ability to use our utensils to eat? And so I wrote goals not just for the feeding that I had seen, but also some of the other things, including some primitive reflexes that we have as babies. And if they're not integrated, they impact our development. And I shared them with the parent, and they brought them to the PCP, and the PCP pushed back on some of my goals and was kind of like, well, you have those as babies, so I don't know if you need to work on those anymore. And I had to, I ended up like reaching out to that primary care provider and providing some education on here's why I'm working on those things and why I felt like they were vital. But there's definitely some pushback on, well, they're not a baby, they're 5 years old, why are we doing that? And I had to kind of be like, well, within like my scope, this is like where we overlap and this is why I'm doing that. And we were able to kind of problem solve that. But that was interesting for the first time for a minute.
Yeah, so there it's kind of the medical hierarchy, but also defining roles and responsibilities that you're hitting on, and that's a really big part of the communication as well. We may not always be interacting with clinicians that went to UNE, so they may not have the same kind of background that you have with regard to trying to practice in a collaborative setting. So just kind of a follow-up to, in addition to the hierarchy, have any of you encountered challenges trying to explain to others what your role and responsibilities are and what your scope of practice entails?
I think that's almost sort of defines what the experience of a social worker often is. Everybody wants one, but nobody knows what we do. So I have a story. It's a bit of a dramatic story, but I was working as a substance use counselor for an opiate health home program a few years ago, and I had a number of clients who had complex PTSD and were in recovery and had lived in poverty and as a result had terrible dental care and had two gentlemen who had just lots of rotting teeth and a lot of pain in their mouth. And they did not want to go to the dentist. And I had sort of gotten them to the place where they were open to going to see a dentist. They were evaluated and then referred to an oral surgeon. And first of all, the oral surgeon was very strict. If we were 5 minutes late, we were turned away at the door. And it took a lot of coordinating just to get us there, and a lot of fear and a lot of anxiety and a lot of getting someone out of the car and into the office. And that is oftentimes when so this one gentleman, we were turned away at the door 3 times because we were 5, 6, 7, 8 minutes late. So we had number 4, and that was our last opportunity. And he was not able to sleep. His mouth hurt so much. Big guy, big guy, right? And we went in, and I said to the oral surgeon, and I had called the oral surgeon before, but I reiterated, I said, this gentleman's in recovery, so he wants local, and does not want, and as far as prescriptions, he really wants to just get Tylenol afterwards. And he said, well, we'll see what he needs. And then I said, I've worked with him for a while, and he can get really nervous. And when he gets nervous, he gets pretty big. And he has asked me to be in the room while you're performing. And he said, that's not okay. And so I turned to my client, and I said, I'm not going to be able to go in there. And he said, well, as long as he behaves himself, I'll behave myself. And the oral surgeon sort of puffed out his chest, and he said, well, you better behave yourself. And I was like, oh, God, this is... So they went into the room, and the tooth was actually successfully pulled, but my client was held down. And this is someone who had been abused extensively, and his trauma response was to fight. And so when he was held down that last time, he struck out. It was almost a reaction. Anyway, the oral surgeon ran out of the room, and he asked the administrative assistant to call the police. And he told me that my client was too dangerous and that he would need him to stay there until the police came. And I said, I bet I could just get him out of your office. And he really did not believe me. And he said, well, you can give it a try, but I don't think it's going to work. And the police are on their way. And I was able to get him out of the room and into the elevator, but he followed us. And then he started to get into the elevator with us. And that is the first time that I felt nervous for my safety, not because I felt my client was going to hurt him, but I felt like something was going to happen between the two of them, and I was going to be in that elevator. And so I had to basically tell the doctor that he had to stay outside of the elevator, and he was very concerned about my safety, and that he was protecting me. And I had to essentially tell him, you are not protecting me right now. You are actually making me more in danger. And we left. And I think that it was a traumatic experience for all of us. I still remember that. And it makes me really sad that the doctor and I really could have worked well together. And so I think hierarchy and communication and roles. And he didn't quite understand how I was as important in the experience as he was for the client.
Yeah, I'm sorry to hear about that experience, but thank you for sharing it. That is very powerful. Yeah, one thing that you brought up that I'd like to hear a little bit about is the patient being a member of the interprofessional team. So a lot of the literature that's out there talks about the providers, but there's not a lot of emphasis put on empowering our patients to be an active member in making care decisions. So that was a great example of trying to empower the patient and listening to them. I'm wondering if there are any other examples of involving the patient and or their family in care decisions and being part of the team.
I had recently, only a few days back, it's a simple, or maybe deceptively simple example, I think, but I've, for some time now, gotten into the habit of, let's say you're going to see someone who's in an ICU, and maybe they're trached or they're intubated but awake, and they know you're there, they establish eye contact, they nod yes or no, but they cannot necessarily communicate, have a full-on dialogue. And there's a family member next to them, and the family member is just eager to hear what's going on. I've gotten in the habit of just asking the family member, hang on 1 second, please, looking to the patient, and is it okay with you if I discuss this with your family member? 9 out of 10 times they'll say yes, absolutely. They'll nod like not aggressively, but happily. And I mean, I didn't make much of it at the time, but I heard later from a different provider that when I left, the family member turned to that other provider and told them, that guy is the only person of all the teams that has actually said that. And they appreciated that. And I'm a big proponent of making sure that the person is involved in their own care, because ultimately it is their health. you're proposing a plan, you're proposing a treatment strategy, a diagnostic strategy, whatever it may be, but ultimately it is their health. And if they don't feel involved in that, it's only going to go so far. And especially if you have somebody who has any type of behavioral disorder, psychiatric disorder, it becomes really challenging if they don't feel invested in their own care. And if you can do anything you can to provide that to them, it's very empowering, in my experience, at least.
Yeah, that's a great story. Are there any others related to involving patients in the IP team?
Yeah, I can speak to that. So mine is a little bit of a different experience because I work with kids. And so my youngest on my caseload is 2, and the oldest that I work with right now is 14. So quite the range and ability to communicate what exactly they want or need or things like that. But when kiddos come into the clinic, there's always a time in the evaluation process that I ask like them questions, and often it'll be like, what are things that are really like easy for you to do in your day, or what are things that are really tricky, or what are things that you might want to learn, to kind of gauge them a little bit. And then I ask like the same things to their parents, as well as looking at the paperwork they filled out. And then when I go to write their goals, we write our goals for a year. And so I take what I saw in the eval, what the parents filled out, what the child or the parents' responses were to create the goals, and then I send those to the parents to sign off on before they become a part of their plan of care.
That sounds great, involving them throughout the thing and thinking about what it looks like moving forward into the future. That's excellent. One thing that a lot of the interprofessional literature talks about are problems with interprofessional teams. Rarely do you find anything that talks about things that go well and kind of positive outcomes. So I'd like to kind of switch the perspective here and maybe talk about an experience where you collaborated with another health professional and saw that it had a really positive impact. And then maybe what was it about that collaboration that made it so successful? Yeah.
So part of my per diem job is I work for the centralized refill team. So that is monitoring refill requests that are coming in from patients and basically being a second kind of set of eyes. The PCP is it's something they prescribe before to the patient, and then this is something that I can sign on their behalf to continue the patient taking that therapy. So something that I've been really passionate about is deprescribing, which I think people think is a little funny because I'm a pharmacist and they're like, oh, you push meds. And I'm like, I mean, I count them. But deprescribing is just as important. We have a lot of patients that are on complex medication regimens, and a lot of the time, some of them aren't necessary to be continued. So some of the things that the team that I'm on have caught just recently, someone had like Plavix, so that's a antiplatelet medication, and they were supposed to be on it for 1 year for whatever incident they were using it for cardiac-wise, and then the therapy was supposed to be ended. And it was like the refill request just kept coming in and people were potentially refilling it. And so we're like, hey, this wasn't supposed to be long-term therapy, or it was supposed to be like a short-term course of that therapy for that patient. And then proton pump inhibitors are another big one. I don't know if you guys are familiar with those at all, but people tend to get on proton pump inhibitors and be on them for forever. And those aren't their intended use, ideally. And so I've had a lot of patients. Actually, this one case comes to mind specifically. It was an older patient. I was looking through her chart. It was like an omeprazole refill request, fine dose, 1 daily of a 20 milligram. I'm like, yep, looks good, looks safe. And then I was looking at her history a little bit, and I'm like, she broke her hip in this past year, and she's severe osteoporosis. I'm like, should we be considering stopping this PPI? And so I ended up messaging the PCP, and they went through with ending that therapy and doing a trial run to see if her GERD symptoms were controlled without it. So that's been a really successful, like when my recommendations are accepted, it is validating.
Yeah, thank you for paying such close attention. I hope my pharmacists are doing the same. For sure. Other examples of when it's worked out really well?
I have an example. It's sort of a twofer. I had a client who in the OHH program, so he was in recovery from opiate use and also experienced severe anxiety. And so when it's documented that you're in recovery or there's a history of substance use, it's very difficult to obtain a prescription for controlled substances. and he was buying Ativan on the street. And we both agreed that that was not the best solution. And he had asked his PCP and the psychiatrist for a prescription, and they said no. So I had a relationship with them because I had gone into appointments with other clients. So that's a important point, I think, is that I had a lot of relationships with doctors and psychiatrists because I would just attend appointments. And so I had these relationships with these people, so when real advocacy needed to happen, I already knew them and they knew me. And so I went in with my client and we had a conversation about what was happening for him, and I advocated for him to get a 1-month prescription of 3 Ativan. So he would only have 3 for the entire month. And we both knew that just having them was going to reduce his anxiety, and the psychiatrist was able to get there in terms of being comfortable with that. So just being able to have that relationship, and the psychiatrist really did not resist much. It was just, I want to have a conversation around mental health and around substance use with somebody else's perspective. And then they sent us to Genoa Pharmacy, and I just want to shout out to Genoa Pharmacy because they always pick up the phone. I can always call them directly, and I can call and say, someone's coming in, can you help them out? So we went over to Genoa, and he was able to fill that prescription right away, and he had a conversation with my client, and we continued to go back every month and pick up the Ativan, and my client was steeped in misinformation about vaccines. There was no way he was getting a COVID vaccine when I first met him. And after 6 months of going to this pharmacist and him being very personal with him, he started to tell him that he had vaccines available. And eventually, my client agreed, partly because he could take him right in the back and give him a vaccine when he picked up his Ativan, so he didn't have to have a separate appointment. And that one day when he was ready, he said, okay, let's go in the back. And so just by, my client disclosing to me that he was buying Ativan on the street led to him actually getting a COVID vaccine.
Yeah, those are really profound, great examples. So that's fantastic to hear. A couple of things I'm hearing are that having clear, open, good communication with the patient, but also with members of the team, and then also establishing relationships with them can be the extra little step that you do as a member of an IP team to really try to bring home deliverables with regard to patient outcomes and strategies. Yeah, I have one more question I'd like to ask, and then we're going to open it up for questions from the audience. And the final question, just because we do have a lot of students here, is if there is something that you know now that you wish you knew as a student with regard to working with other healthcare professionals, what would that be?
Yeah, I think for me, it was no question is silly to ask your colleagues or coworkers. They're not going to think anything different of you for asking the question. If you have to ask it more than once for more than one client, they'll still answer that question again. And just the ability to be really honest and open, especially there's not many of us at the clinic that I work at. And so the same PTAs treating the same kiddos that I'm treating, the same speech therapist. And so being able to ask those questions, or sometimes if they're free, I'll grab and be like, hey, I'm noticing this. Can you pop in and kind of observe this and give me that perspective has been really helpful. And so I feel like when I left, I was like, okay, I got my master's. I should know all these things and go out to the field and be able to use it. And while that's true, a lot of things, being able to ask questions is really helpful, and seeing the overlap between an interdisciplinary team is really great. And so always ask the question.
Really just piggybacking on what you just said, making sure you keep an open mind. And I mean that in a very specific way. It's a very cliched phrase, but I recently had a scenario where I was asked to teach a session for our trainees, for our fellows, on Clostridioides difficile infection, which is healthcare-associated infection, typically. And when I've encountered that scenario, often the gastroenterologist, if there was one involved in the case, they would use a specific type of test. And it's one of those where every time you see it ordered, you're like, why are you ordering? It frustrates you. And then as I started preparing for this lesson, I started reading the American College of Gastroenterology guidelines. And lo and behold, recommendation number 3, always order this. I felt so dumb because I was getting frustrated by this. And all of a sudden I realized, well, they're ordering this because that's what their professional guidelines are suggesting. Where the Infectious Disease Society of America may say no, theirs clearly say yes. So you have to understand that the lens that the person in front of you is using may not be the same as yours. So make sure that before you pass any judgment, before you start getting frustrated, try to figure out why are they asking what they're asking, why are they suggesting what they're suggesting, and usually it boils down to a conversation. Sometimes even a text, but not as often. Usually more of a conversation. I found that very eye-opening, and this, again, this is recent. One of the beautiful things about medicine is it always challenges you. No matter which subsection of medicine you're devoted to, it always challenges you.
That's great. Thank you. Yeah. What I'd like to do now is open it up to questions from the audience. So if you do have a question for one of our panelists, just raise your hand and we'll get a mic to you. Okay, while people are building up courage, we do have one here.
Hi, I was just wondering, have you ever come across an issue with like administration that aren't actually treating a patient, but are trying to make guidelines in regards to and how you deal or have dealt with that in the past to just say, this is my care model and the administrative side may not line up with that model?
That's one of the big lessons I've learned recently, and this happened in 2020 during that dark period of time. As I was getting more and more involved in epidemiology, infection prevention, the hospital I was at the time was actually a little bit, as that started calming down, some of the other issues of usual reporting to CDC, to National Health Safety Network Association came into place. Joint Commission, all of those reporting agencies that hospitals are supposed to provide metrics to. And the administration was pushing this strategy to try to make some numbers look better for the purpose of reporting. And I went to my division chief at the time, just amazing human being, amazing mentor. And what she told me is make sure that I understand where you're coming from, because our focus is always going to be patient care. But if you want to keep on learning, if you want to keep advancing in your profession, make sure that you understand what the needs of the administrator are as well. And what hit me then is, as a clinician, as a healthcare provider, I would hope that everybody in this room is in it to provide patient care, to care for the person in front of you. The administrator sometimes doesn't have the luxury of seeing that, and what they have in front of them is the requirement that the federal and state government is asking of them. So similar to the discussion with the gastroenterologist, you have to sit down and try to understand, okay, why are they pushing this? It's clearly not related to patient care. Well, there may be another reason for it. And ultimately, you have to bring it back to patient care, but you have to also understand that the hospital has certain legal reporting requirements that have to be met. So your job is going to be to find that middle ground where how do we fulfill that while at the same time continuing to provide the highest level of care we can.
Yeah, for me, when I was practicing, what you're mentioning right now is something that I encountered regularly, and it took me a long time to get to the point that you're at. One of the things that my default was I would assume negative intent sometimes on behalf of the person trying to advance a particular agenda. So one of my mantras in the clinic was don't assume negative intent and try to get to the root of why are they asking me to do this. And like with those conflicting guidelines between your professional organization and another provider's professional organization, that's a lot more common than you would hope would be the case. And also sometimes interfacing with the business side of medicine can be really complicated. And that's one thing I think that when we have interprofessional conversations, we can do a better job talking about is just what does healthcare look like in the United States in a capitalist system, and what are those tensions or those synergies that either make healthcare outcomes improve or maybe not improve based on some of the business decisions that are in there. Yeah.
I think sometimes also we take systems at face value in terms of like, this is the way it is. And I think what I have learned is that there's a lot of wiggle room, and there's also, it's worth asking the intent behind something. I had a client who needed a surgery, an outpatient surgery, but so they scheduled a blood work appointment, an assessment appointment, another assessment appointment, and then his procedure, all in Scarborough. He lives in Portland. He does not have a car, and he does not use public transportation. And he is allotted 22 rides for the entire calendar year through his Advantage plan. So that was going to be a third of his rides for the year. And I called the office with him and I said, is there any way they can be combined? Maybe assessment and blood work or can all three be combined? And she said, oh, well, I was trying to, yeah, we could do that, but he'd have to wait, right? He'd have to do an 8 a.m. and then an 11 a.m. and then a 3 p.m. And she said, so I don't want him to have to wait all that time. So that's why I made 3 separate appointments. And I said, do you have Wi-Fi? And she was like, yeah. And I said, so just put us in there for the day. And then it's just one ride that he can take there, he can hang out, and he can leave. And she thought she was helping, right? But she didn't have all the information. And she was happy to schedule it a different way. She just doesn't get that kind of request. So sometimes it's worth asking the intent.
The best of intentions there. Yeah. Other questions from audience members?
Hi. I guess my question was about the active patient involvement care plan. You guys talked about how there's like a good communication between you and the patient, especially when it comes to the care plan. I guess what I was wondering is if that's just basic like patient confidentiality, kind of like you're working close. Sorry if that doesn't make any sense, but if that's like standard practice, I guess. I feel like that's a standard thing that's kind of normal, but maybe it's not. I don't know.
If I can drill down just a little bit more. So developing like kind of a confidential care plan between one provider and a patient, and then the provider sharing it with other providers, is that the source of the conflict potentially?
Yes.
Yeah. What do we think there about sharing potentially protected patient information with other providers? I'm sure we have stories.
So I just did my annual HIPAA retraining. So as far as providing information, I personally get a lot of calls from providers calling for med lists, whether it be a patient's transitioning care, they're in a long-term care facility, new PCP that uses a different EMR system, it doesn't have past records. You can share patient information that's relative to their care plan with a provider that is also HIPAA compliant and for their care. So as far as the confidentiality aspect, you're protected if it's like a continuity of care and you're doing it for reason, like sharing information with a provider. Does that answer your question? Yeah. So I feel the same way. Like I remember the first time a doctor called me for a med list, I was like, no. And I'm like, okay. But yes, because you're at the end of the day, it's what you need to do to provide the patient the continuation of care that they need safely, and the provider's also caring for them.
Yeah, I just want to add one thing to that, and then I think some of our panelists have more comments. One thing that Katie was kind of touching upon is trying to involve the patient as a member of their care, and it's a really tricky line between honoring their privacy and some things that they may have shared with you confidentially versus what you need to share, maybe if you're a mandated reporter, as you'll end up being, or if it's information that you think is vital for another provider to actually know. So those are really tricky conversations oftentimes to navigate. And it's really great when you're doing your training to rely on your preceptors and ask them a lot of questions about where they draw that line, because some of those are subjective calls for sure.
For us, because it's like kiddos and things like that, we have to have a release form signed for different care providers. So when they do our policy and procedure paperwork, there's a place for them to put their PCP so that that release can be signed right away. And then if they have other care providers, if they want us to send like their treatment plan or their goals for like an IEP meeting, if they get services in school, we have the parents sign a release form on our end before we can reach out, email, phone, anything like that to other care providers teams to cover that. And then for the mandated reporting piece, I remember graduating and being like, oh, we did the training, but like, hopefully I'll never have to use this. And that's not always the case. But we redo that yearly. And as a team, we talk about like what those expectations kind of look like with our owner and then as a team as well. And sometimes we have kiddos that we both treat. And so I'm never like in the clinic by myself. So there's almost always someone else who might see something as well. And we can kind of problem solve that together should we need to report something.
Something to add to what I was saying too, it also the urgency of which the other provider needs the information, because we have documentation and processes too for like someone's getting a new PCP. So usually we'll ask them to fax us letterhead with a formal request. The patient come in and sign like a form for us to give permission. That's like a different sort of HIPAA release. But if it's like the ER's calling and they're like, hey, someone's unconscious in our ER, the family says they used their pharmacy, are they on a blood thinner? Like that's information that we're not going to be like, well, you need to send me a form. So again, urgency also kind of affects the release of information in that sense. But there are procedures that we follow too. When you said paperwork, I was like, oh yeah.
And also barring an emergency scenario such as that one, I love our clinic administrative staff because there's no way I'm going to remember all of that stuff. And there's so many laws and so many subtleties to them. Usually if the patient asks me, can you please send this to my PCP, all I do is document it in the note at the end of the day, per patient's request, sending to Dr. blah, blah, blah. If you're not so sure, your admin staff is so great because you can just as easily as walk to the other room, hey, patient is asking for this, do you know if that's okay? They usually will know the answer. And most of the time, if it's direct patient care, I mean, you're not going to call another provider and, hey, dude, this case was super cool. You're not going to do that. But if it is, I'm transferring care to your office, this is the latest development, this is the medication they're on, that's a very different story.
Great. Other audience questions?
So kind of talking about like boundaries again, to what extent do you feel like you can speak on outside of your scope of practice when it's in the best interest of the patient, that you feel like you can kind of challenge even if it's not necessarily your scope of practice, but you're like, no, like this is for the patient's best interest. To what extent do you challenge your scope of practice?
I say a recommendation is a recommendation if you have the best interest in the patient of the patient in mind. I wouldn't say, I'm not recommending working outside of your practice, but if you think that you are noticing something or you have a concern, like, oh, hey, while I was reviewing this medication this patient's been on, I noticed they haven't had, lab work falls, I think, even within pharmacist practice. But you can make recommendations that might be a little bit on those gray area, but they're just that. They're recommendations. I think having reasons behind your recommendations to support your concern is important, and just making sure you're working with that team to advocate for not only what you think, but for the patient's safety is important.
Yeah, medical errors are obviously a huge challenge in any healthcare system, in particular in our nation. We have the equivalent of 2 747 jumbo jets crashing every day are the number of people that die because of medical errors every day in the United States. And you can imagine if we had 2 jumbo jets crash today and tomorrow and the next day, we'd do something about it. But in healthcare, we've been very slow to kind of address some of those problems. So one thing that could be valuable to maybe take out on clinicals is if you see something, say something. There can be simple calculation errors, like with a dosage of digoxin. If you move that decimal point one way in one direction, you can kill somebody. And those are honest mistakes that people made. Grabbing the wrong medicine. A lot of the meds that you might be using, like on a crash cart, they're much better now. But when I was in school, the vials would be almost the exact same size and almost the exact same color. So it was really easy to make errors. So in general, and again, if it's an emergent situation, if you see something that might be an error, please say something. If it's something where you have a little more time and space, I find that it's always better to try to have those conversations privately. You can ask someone to step out in the hallway and ask them a question or follow up that way. And most of the time, people are very grateful that you said something and intervened.
I would never challenge another profession in terms of what they're doing and their knowledge. I find that I push a lot, specifically around allowing people to have self-determination. I think there's a lot of incredibly good intentions and goodwill and knowledge and skill and expertise and possible solutions for someone's issue. But if the person doesn't want that, they get to make that choice. And I think sometimes I can really help deliver that message in a way that people can hear. And I also find myself really insisting that providers believe the patient. I have a lot of clients who, when they're sitting in front of a medical professional, the medical professional doesn't necessarily believe that they remember information correctly, that they know their personal history, that they know their medical history. And so I find that I push a lot in terms of this person knows their own history. They know their body, and it's their body to live in for the rest of their life, so they get to make the choice. So I don't know if that answers you.
Yeah, thank you for sharing that. That's really important, I think, to hear for sure. Many medical school and health professions ethics classes can be based on just some of these points that are coming up about bodily autonomy, about free will and decision making, and honoring patients' ability to make decisions for their own healthcare, even if that decision might not be yours and might shorten that individual's life, that at the end of the day, it is their decision to make. Yeah, looks like we have a question in the middle here.
Hi, you all kind of answered this, but what are some helpful tips for dealing with the challenges that come interprofessionally? Like, what are things that you find yourself doing, or what have you learned to do when those challenges come?
This was a really great question. I am huge on advocate for yourself, especially when you're a new grad. I'm the first to admit, and I'll tell all the new grads that come by me in the pharmacy, I really struggled when I first graduated. I was so worried about doing the wrong thing, about making an error. It's a lot of pressure. You want to serve patients and you want to do it safely. So definitely advocating for yourself if you need help, just even mental support if you're struggling, making sure that you feel comfortable within the network that you have of the company you work for, or the hospital you work for, saying, hey, I am struggling, like, what can we do? So being able to get that support, I think, is really important, and it's okay to say you need support, especially in the beginning. You're gonna need it, okay?
If you have the option to, to have your first position out of training in a place where there's people who have been doing this a lot longer than you, that is super helpful. I was lucky. I mentioned one of my mentors a second ago. That was my first job at an academic center out of training. That was in New York. She's an amazing physician and an amazing mentor. There were several other people within the division that, I'm out of training, I'm hesitant, this case is super complex. I know what the guidelines are telling me, but the guideline cannot look at the person in front of me. I can, and something doesn't quite match up. I always felt comfortable reaching out to any of them and say, hey, can I run this by you? If you have that luxury, take advantage of it and find those people that are receptive to that type of interaction and really stick to them, because they'll become friends and they'll become colleagues, and you can only learn from them.
Excellent.
I was just going to say, I for a second lost my train of thought. But going off the mentors, being able to ask questions. My boss is so knowledgeable and she's been doing it for so long. And so I really leaned on her at the beginning and asking her lots of questions, or if if a parent had a question for me, I had to be comfortable saying, I'm not so sure about that. Can I get back to you on that? Or I'm not 100% sure of that answer. Can I think on it? Or circle back to you and I'll send you an email, or next session was really helpful. So I think whether it's talking to a colleague or a parent or a patient, knowing that even especially as a new grad, you don't know everything, and taking what you learned in a classroom and then applying it to real life scenarios, and the person being right in front of you is a really big step and a really big deal, and can be tricky. And no two patients or clients are going to be the same, even if they fall under the same umbrella. And so being comfortable and confident enough to say, I'm not so sure on that. Can I get back to you, or can I problem solve that in return to answer that?
Yeah, that's a wonderful example. We talked about communication and relationships. Part of that is building trust with others. And I think something that goes a really long way in doing that is opening up and being open and honest and exposing some of your vulnerabilities. Again, we all learn new things all the time, especially in healthcare. It's such a fast-paced, moving set of professions with new information coming out all the time. And it really is okay to say, I don't know, or I'd like some help with something. I think you'll find that you'll win members of the interprofessional team over much quicker by exposing some of your vulnerabilities and asking for some collaboration on some decision making than doing the opposite of kind of acting like you know everything or trying to cover up for a deficit you have. That can erode trust, but it can also lead to obviously poor patient outcomes.
The therapist in me is coming out. I also just want to say that, this is, working in health professions is hard. And you are in the face of people suffering every day. And you're there because you want to help people. So what I would say also is embrace the fact that this will impact you, that no one is immune, and it will impact you, and it will impact you emotionally. And so think about what helps you process hard things. If it's peer support, if it is going for a run, if it is journaling, if it is talking to mentors, but prepare yourself and know that that's something that you're going to want in place, and don't wait for it to be necessary. Put it in place before it's necessary, so that you're in the habit and it's in place.
Yeah, developing healthy habits when you're not in a time of stress and crisis is something that's really important. And taking care of yourself, this wellness idea, knowing when you're getting stressed, kind of what are those warning signs? For me, it's eating a box of pasta. I'm like, maybe I'm stress eating. So, just know yourself and know kind of what maybe some of those warning signs are, and trying to do some self-care in there. One really important thing that a mentor would regularly tell me is you can't take care of others if you're not taking care of yourself. And I really do believe that you need to show up and be fully present when you're interacting in your professional roles. And a big part of that is simply that self-care. Yeah. Yep, another question in the middle here.
Kind of like backpacking off of the whole self-care thing. Obviously, you're not able to talk about certain situations with maybe like people you live with, stuff like that, because of like patient provider confidentiality. What are like outlets you have for just kind of like getting out your feelings for that? Because obviously you can't really express your emotions to your patient because that may be unprofessional. So like, how do you go about kind of having a way to express that without it all like bottling up inside and creating more issues for you on your own?
Well, I can share that I am in a therapy group of therapists.
Is this a joke?
And it's not just us sort of sitting around talking. We actually role play clients who are getting us activated and we're stuck with. And so so it's really wonderful because it's peer support. We can talk about the work with each other. Of course, like de-identified, but then we actually are going through like reliving what it's like, and so we're getting witnessed in our work because we don't get witnessed, right? It's just me and the person in a room, and so no one sees what happens, and that has been incredibly helpful because when I come home and my family says, "How was your day?" No matter what, I just say, "It was fun." And I need somewhere to put that. So that's been really helpful.
I agree. I communicate with other pharmacists. If there's like something that's festering, and I'm like, did I handle that situation right? Did I make that right decision? My husband, I don't talk to him because he's not medical either, so he doesn't even know what I'm talking about. And of course, it's all de-identified. But like I have like a couple pharmacists that I usually work with very regularly. And I'm like, hey, I want to run by this situation with you and just give like a brief summary of like, and then get their opinion, like kind of bounce ideas. I think talking it out with someone is so important that can understand, but again, de-identified to protect the patient and HIPAA, things like that. But just to help your own and kind of see another person's perspective of the situation.
Great. I think we have time for just one more question. So any final questions? Yes.
Unless someone else has one. Is there another profession that you work with now that you maybe misunderstood in the beginning, but now you have a complete different, you've learned a lot more about them?
I'll go first here, just because we have a social worker here. My big knowledge gap and blind spot when I was a student and when I was training was working with the social workers. I had no idea what they did, how much they did, how important they were in networking with all the other providers and helping the patients. And I just feel like it was an incredible handicap because no matter what we were trying to do on our side of interacting with patients, if we didn't understand the rest of the pieces of their lives and the barriers and challenges that they were facing, that no matter how good the care plan was that was developed, like the example you gave about the number of rides being limited or things like that, that kind of non-compliance, if you will, or not following through with some care plans, a lot of it will end up hinging on your social worker that you work with. So just a shout out to social workers. Any other professions?
I'll start by saying that for probably historical reasons, my profession being a physician, usually even the word doctor kind of gets put on a pedestal, and it really needs to be toned down, because when you're on the floors and you look at what the nurses are doing day to day and what the PTs are doing day to day, and the OTs and the PharmDs and the case managers and even the folks who dietary who bring the food, I mean, it became 2020 again. It just emphasized it for me. It's not like it wasn't there before. It became really like acutely apparent to me then. So I've alluded to this before. The beauty of medicine is it always will challenge you. Just when you think you understand it, it throws a curveball at you, and that is one of the things. Just everybody's playing a role, even if you have acknowledged it or not.
I just want to say it's occupational therapists and pharmacists. I mean, that's. I was one of those people who thought pharmacists were there to push meds. Absolutely. All kinds of bias. And again and again, I meet pharmacists who are all about deprescribing and really so much beautiful bedside manner. And occupational therapists, I had no idea. I had no idea until I had to work with one, and the amount of mental health work that is at play, and the family dynamics. I really was, I'm glad that I learned, but I wish I had known before I was face to face.
I think in OT in general, what's been fun is to see the overlap with a bunch of different professions and things like that. One of the things that I love so much about OT and why I chose OT is that I can really meet clients and patients where they're at, and whatever's impacting their day-to-day most likely falls under my scope, or I could, address it in some way that does fall under my scope, which has been really fun. And just seeing the overlap, like with our SLP in the clinic and the social emotional work that she does and the executive functioning and all of those things, being able to share mutual kiddos and be like, I saw this today and I'm not sure like where the root of that was coming from. Like, what did you see in your session? And being able to kind of problem solve. Like, this was tricky in our session and it appeared to be from this like root cause. And I was like, oh, like that makes sense. And that's why I was seeing it here. And so that's been really fun to work interprofessionally and see the overlap, and then also problem solving, kind of like where it comes from, has been fun.
Yeah, thank you very much. I have a couple of housekeeping announcements to make, but first what I'd like to do is just thank everyone for coming and sharing your questions and participating in the event, and just ask for a round of applause for our panel members for sharing. Thank you so much for sharing all of your experiences. It was really impactful for me to hear, and we really appreciate you coming and sharing those with our students and our community. In terms of housekeeping, just a reminder, I made this announcement at the very beginning. On your tables, there's a card with a QR code on it, so please be sure to scan that, especially if you're a student seeking the interprofessional honors distinction. It's a mechanism for us to track your attendance. And then the other thing is there's a brief survey there that we can gather some information to try to make improvements in these programs, and try to get more people involved in them. The final announcement I'd like to make is just a reminder that there's another event that's scheduled for March 26th at noon on Zoom. And it's part of a series being put on by the Center to Advance Interprofessional Education and Practice. And the title of that event is Empowering Voices and Removing Barriers, Advocating for All with Disabilities. So one thing I'd like to mention, if you are a faculty member and would like to be included in this event, in your curriculum, you can reach directly out to CAPE and we can work with you and help make that be integrated into your program. So thank you everybody for attending, and thank you to our panel again.